Thanks, Emily.
मैंने आपको मेडिसिन भेजी, किसी मेडिसिन के पेशेंट को ना डिस्टर्ब।
All right. Welcome, everybody. We're just going to give a few more seconds for everybody to join. Okay. All right. Thank you all for joining today. For the interest of time, I think we should probably go ahead and get started. Emily, what do you think? Good morning, good afternoon, good evening, everybody. Thank you so much for joining us today. My name is Kieran Agarwal-Harding. I'm the one of the course chairs. This is our Ortho-Pediatrics and Oncology session. This is the first time that we're running this conference, and hopefully, if it's well received by all of you, we'll continue to run these. We have a very standard format for these conferences, which I hope many of you are familiar with already. These are case-based discussions primarily, and all the lectures and everything were made available to all the folks who registered for the conference ahead of time. So with that, I'll hand it over to Emily Powis. Emily, go ahead.
All right, thanks everyone. Well, hi everyone. My name is Emily Powis. I'm a second-year medical school at Harvard. I'm a second-year medical student at Harvard, and I've been helping plan this conference. So, like Kieran said, this is Ortho-Pediatrics and Oncology. Our pre-conference survey is on the right here if you want to get started on that. So for our course agenda, today is focused strictly on limb deformity. Following weeks will be on chronic osteomyelitis and primary bone tumors. Just as a reminder for Zoom, if captions will help you, just make sure to follow these directions here. You can take a screenshot to help you. If you click the small caret button, you can select your caption language so that you can see us speaking in any language. And just so that, because we have so many people joining us from so many different places, if you could just make sure you use your raise hand function so we know when to call on you, and stay on mute when you're not speaking. Course objectives are to improve participants' knowledge of limb deformity, chronic osteomyelitis, and primary bone tumor. We also want to foster an international discussion regarding orthopediatric patients and oncology patients and management of the complications. And I think our biggest goal is just to motivate and support the younger generations of orthopedic surgeons practicing in resource-limited settings from around the world. So our course chair and moderator will be Dr. Kieran Agarwal-Harding from Beth Israel Deaconess Medical School, Medical Center at Harvard Medical School. And just a shout out to our Harvard Global Orthopedics Collaborative and SONA Global Organizing Team. This is just half of the team that joined us and the second half as well. So thank you everyone for helping with all the behind the scenes work. To start, we'll have 3 case presentations first from Dr. Mohammed Abdulal from Sudan, then from Dr. Arsène Jr. Ifrène from Haiti, and then we'll have a presentation from Dr. Leul Merid from Somaliland. And then our time permitting, we would love to have these presentations as well from Dr. Sabir Khan from Pakistan and Dr. Dominic Konadu-Yeboah from Ghana. And thank you so much to our case discussants as well for helping us. We have such a lovely team of faculty from around the world as well to help us discuss these cases. They'll kind of be fostering the discussion and giving their expert opinions as we go through each case. So first we have Dr. Richard Gardner from the Hospital for Sick Children in Toronto, Canada. Dr. Saad Ilyas from Gurki Trust Teaching Hospital in Pakistan. Dr. Philip McClure from LifeBridge Health in Owings Mills, Maryland. Dr. Amanda McCoy from UPMC Children's Hospital in Pittsburgh. We have Dr. Leul Merid again from Dr. Ismail Specialty Hospital from Somaliland. And Dr. Sanjeev Sabirwal from the University of California, San Francisco Children's Hospital. And then our last 4, we have Dr. Michael Segbethia from Korle Bu Teaching Hospital in Ghana, Dr. Mahir Thakur from Numerous Children's Health from Wilmington, Delaware. And finally, we have Dr. Lawrence Wicks from Cure Ethiopia in Addis Ababa, and Dr. Ramiz Kudzi from Dartmouth Health in New Hampshire. All that being said, this is our most important slide and our designed plan for the day. So as I said, we'll first have our presentation from Dr. Mohammed Abdulal, followed by a case discussion. And then we will have a case presentation by Dr. Arsène Jr. Ifrène, and then a case discussion. Presentation by Dr. Leul Merid and a case discussion. And then hopefully we'll have time to discuss the cases by Dr. Sabir Khan and Dr. Dominic Konadu-Yeboah as well.
Thanks, Emily. Well, let's go ahead and jump right in. Mohammed, do you want to share your slides?
Yeah, sure. So is it clear?
It's clear, yeah. If you just want to make it full screen and then go ahead. Thank you.
Okay, thank you very much. It's my great pleasure to be here again after almost a year. It's my pleasure to present to you today this case presentation about a neglected supracondylar fracture. My name is Dr. Mohammed Abdulal. I'm from this side. This area is called Sudan. It's part of Africa, just south to Egypt. Maybe you know about the issues that we have in our country for the last 1.5 years about the internal war. I would like to express my great gratitude for this great Arab Institute for continuing professional development. These great members, teachers, and the man in the middle, Professor Muhammad Fadil. I learned a lot from those people, and I was part of the team in 2023. They have a nice professional diploma of 1 year for limb reconstruction surgery. This is my hospital, Sharganir Hospital. Unfortunately, it's out of service since the 15th of April last year. This is one of the recent pictures of it, unfortunately. And this is my Faculty of Medicine, University of Khartoum. So today I'm going to present this case. I've seen this patient by the end of 2022. He is a 4-year-old boy. He presented to me with a right side supracondylar fracture humerus with a late presentation of 4 weeks. And we had a discussion with his mother about delaying the surgery and a wait-and-see policy. The reason for that, why these patients present late in our country, because of so many factors. Number one is the limitations of orthopedic surfaces. It is not uncommon to have a single orthopedic surgeon delivering the surfaces of orthopedics in a single town and the associated villages around. Number two, it is because of the cost of transportation and the treatment itself. The treatment in my country is not fully insured, as well as the cost of transportation. So until the people, they can get the enough cost for transportation and treatment, they get delayed. The third most important factor, which I think it's a very crucial, is the traditional bone setter. The traditional bone setter is a common practice in my country because they are available in every single neighborhood. There is a bone setter. It is a very cheap surface. And one of the problems of the traditional bone setter, I wouldn't say most of them, but the vast majority, they don't have the policy of, I don't know. They would treat every fracture. And this is how they treat most of the cases. These are real cases that we see in our referred clinics. They come with these things, woods and metals, hardly wrapped, and you can anticipate the secondary injuries that happens from these practices. The boy on the right, I had to do Elizarov. The female on the left, I had to do, or she was a candidate for wrist fusion. And if you look at the x-rays of these patients, they were very simple fracture. If they were left alone, they would have healed without any complication. So this is a common practice in the country. So back to the case, a neglected supracondylar fracture. Why no dismantling? So sometimes you can get presentations with cases. You look at the x-ray, the mother bones looks there. You can just dismantle and put everything back and you fire your K-wires. But I had a very bad personal experience with these fractures. You can get a very nice, beautiful post-operative x-ray, but with the follow-up, you get disappointed with the stiffness of the elbow. They know the elbow is not a forgiving joint. Even in pediatrics, they are not a mini adult yet, but still the risk of stiffness is high. Why not to wait until maturity for remodeling? I had a discussion with one of the pediatric orthopedics, and they think that pediatric patient below the age of 4, they can get some sort of remodeling. Me personally, I don't think this is quite exact, because as we know that the thin anterior-posterior diameter of the distal humerus. The second thing, the gross potentiality from the distal part of the humerus is limited. We only have 20% compared to 80% from the proximal part. And is it really a single plane sagittal deformity? I don't think so. The supracondylar fracture is a multi-apical deformity, and it is not uncommon to have some sort of restriction in the shoulder motion. As I listened in one of the discussion, that one of the professors said that it is uncommon to have a restriction in internal rotation of the shoulder with people with malunited supracondylar fracture. So it is not just a simple supracondylar fracture. So this is the X-ray after 5 months. I had a discussion with the mother that let's wait and see if the child could manage to have a functional range of motion. So it's okay. After 5 months, the AP view doesn't look that bad, but on the lateral view, you can see that the anterior humeral line is far anterior here. There is an extension. And on examination, the range of motion is smooth from hyperextension that was about -15, and with a bony block at about 95, 100. So I have the belief once a plateau phase has been reached, this is the time that you have to plan your surgery. So he had a hyperextended elbow with a bony block to flexion beyond 90 or 95 degree, and he has a gun stop deformity. So I think it's crucial from the early meeting with the caregiver, that there is a possibility of surgery. We might need it, we might not. So if you are planning surgery later on, they will not be that distressed because you have a discussion with them about all the possibilities. So what we did for this patient, what I did is a lateral approach, about 4 or 5 centimeters, and I did a closing wedge osteotomy. If you can see here, of course, I haven't took all this chunk. It was just an explanation for the patient. So what I did is a closing edge osteotomy with the flexion of the distal part and fixation with K-wires. The range of motion has improved into 0 up to 150 degree flexion. The gun-stock deformity has resolved. Unfortunately, because the radial nerve is there was no postoperative distal neurovascular injury. You could see preoperatively, I made these photos. He was right-handed, this is right hand. This is the gun-stock deformity, cubitus varus. You can see he has got a locked flexion, about 100 or 95 degree flexion, precisely. He had a hyperextended elbow. This is after the surgery. I hope the video is working for you. You can see that I was quite satisfied that the gun-stock has resolved and he has smooth, near full range of motion. So intraoperatively, I was satisfied. This is the immediate post-op, the AP view, the lateral view. I had follow-up after 3 weeks. There was a good callus forming, and I didn't want to put to get the K-wires and the cast for a long time. So after 3 weeks, I removed everything. I wanted the child to have physiotherapy in a specialized center, but as I told you that the problem is these patients are living in remote areas. It was very difficult to have them every week, every 2 weeks. And his mother was nice. He was clean. Oh, sorry. So she told me that I can do everything you tell me at home and I will keep you updated. So I agreed on that. We started gentle passive and assisted active home-based physiotherapy exercises. And after 3 months, this child was able to get more than 150 range of motion. She sent me that video after 3 months from the surgery. This is Arabic language. You can see smooth, near full range of motion of his elbow. The child was happy, his mother was happier, and me myself, as this was the first case, I was the happiest part. I was the happiest person in this story. So as a summary, and these are my personal beliefs, I think delayed management of neglected supracondylar fracture humerus had the advantage of minimizing the soft tissue injury. You can do it with a smaller cut, a submuscular approach. The respect of the soft tissue means better outcome. A long wait and see policy is advocated by some surgeons, but once a plateau phase has been reached, I think it's the time to schedule your surgery. I think in our country, the WhatsApp follow-up is very important. Those patients cannot have an access for you easily, so I don't have any problem to give them my personal number. They can send you photo x-rays from time to time, the photos and the videos, and you can guide them if there is anything wrong, what to do next. Thank you very much.
Thank you, Mohammed. So the reason that I selected this is, you know, when we think of limb deformity, we think of congenital or acquired deformities, you know, but I think one of the most common limb deformities that I've seen when I'm working in limited resource settings is actually neglected trauma, especially of the elbow. So thank you very much for presenting this case, because I think you did a very nice job managing it. If you don't mind, could you go back to your preoperative x-rays where you sort of explaining the way that you did your osteotomy? I think this is a very important teaching point. Could you tell us like how you approached it? You did dual medial and lateral approach, it looks like.
Well, actually, I don't have an experience in this field. That was my first case. Honestly, what I did is just a lateral approach here. I did like a K-wire guide as parallel to the joint. We don't have a problem of mechanical accidents in the upper limb. So what I did is just put like a guide wire of K-wire, and I did a wedge like in a triangle, and I just with making the medial hinge was intact, and I just twisted the elbow laterally to correct the cubitus varus and inflection. So I just did it as simple as that.
Great. So, you know, our resident, you know, on this call, we've got a pediatric upper limb expert, Dr. Ramiz Kudzi. Ramiz, do you have any thoughts on this one?
Yeah, thank you. It's an interesting case. Obviously, neglected is common, and your approach to wait and let it heal as opposed to taking it down. I like your idea of doing just a lateral approach with a lateral wedge. It's hard to correct extension just with the lateral wedge, but I think you did a great job of getting cross fixation, because one of the challenges if you just do a single-sided approach is it can be unstable and when follow-up is unclear. And so I appreciate that you had cross wire fixation, which wouldn't be the norm for an acute fracture, but it makes a lot of sense in a neglected fracture. Maybe for others on the call, you can, if Dr. Mohammed, if you can mention how you put the medial pin in, because there's been a lot of discussion around that in the field. Do you prefer to make a small incision to protect the nerve, or do you prefer a more percutaneous approach in the setting of deformity?
Well, in the setting of deformity, I don't have a problem with crossing or just lateral, but if I'm going to do a crossing maneuver, I always start with the lateral pin. Once it is stable, I do some extension, and I palpate the medial epicondyle, and just I put the K-wire through the bone. In the past, I used to do small incision, but I think after you fix the lateral side and you do extension, the bony landmarks can help you about firing the K-wire without any problem.
Yeah, I think you're right that it's less than 1% risk of hitting the nerve coming from that medial side for folks that are experienced like yourself. And then perhaps if others are finding themselves doing it less often, a small 1 centimeter incision can be very safe. The other thought I had on this is with your approach to wait and see how much it remodels when it plateaus, I was debating in my head whether just recreating a coronoid fossa by shaving down the bone. And I think in my head that made more sense than cutting the bone. But when you showed your x-rays, I think your approach actually was safer. And so I like, again, your approach of this doing this from a lateral approach, I think is just the safest way to do it. And I appreciate you sharing the case.
Could you go to your lateral, please, Mohammed?
Sorry?
Could you go to your lateral x-ray, please, just so we can see that?
Yes. Okay.
On the pre-op light there, on the pre-op lateral, one idea, could be we do this in fingers where instead of correcting the actual deformity, just shaving down the bony block. so they don't have the healing phase. They can get moving faster. But in order to access that, I worry about obviously the neurovascular structures that are there. And by you just doing a straight lateral approach and osteotomy, I think you fix the problem in a safer way. So that makes sense. But for those who don't have maybe a follow-up, or they're worried about bone healing with nutritional deficiencies, any of those reasons, another option is to shave the bone to fix the bony block and allow for improved motion, because the healing is just faster, but the surgery, I think, is less safe.
Dr. Segbefia, Dr. Ilyas, would you guys have managed this any differently in your settings between Ghana and Pakistan? Feel free, anybody who wants to chime in. I don't mean to just call on you guys.
Okay,
Yeah,
thank you very much. This is Michael from Ghana. I probably would have waited for at least 2 years before intervening. Wouldn't have gone in within 5 months of the injury, because I know that by that time the potential risk of myositis ossificans would have reduced considerably. And one thing we have noticed here is, especially when we have patients who have come from herbalists and we go in quickly, we end up with a lot of heterotopic ossification. So on my part, I would have waited for a while, maybe not within 5 months of the injury. I don't know what other people think.
I had a discussion with one. Sorry.
Yeah. I would like to add. We do get a lot of cases of malunited supracondylar fractures over here, and I usually wait because in these patients the main problem is restriction of movement, that when they come to us, and then there is a deformity. So if we do an osteotomy there and then obviously we're going to have to immobilize the elbow again for another 4 to 6 weeks. So usually my approach here, and plus I'm very afraid of myositis ossificans here. So my usually approach is to start with physiotherapy, and if there is a bone block which is blocking it, after some time of physiotherapy, I just take it out. I don't worry about the deformity right now, because that I'm going to do after 2 or 3 years. I'm not, once the child is about 7 or 8 years of age, then I'll be doing it. Usually my approach is a bit slower in this patient. I don't worry about the deformity right now. All I'm worried about is the myositis ossificans and further period of immobilization.
Mohammed, did you have a comment on that? I think we also have a question, so I'll let you.
Yeah. I had a discussion with one of the colleagues, and he is a pediatric orthopedics actually. And I've been through a paper that they are thinking about if you are managing a malunited supracondylar fracture in children below the age of 5, it might remodel. So it's not about, I agree, it's not about the deformity, but it might remodel and they might have an improved range of motion. Yeah, I'm not experienced in this field, but from what I have seen here, the remodeling area, it's not about the deformity, but the range of motion. So what I have seen here, the remodeling capacity or potentiality is very limited. Even for the smaller children, you can see children that had malunited supracondylar fracture for years, and they still come with decreased range of motion. I agree that early dismantling for those coming within 3 or 4 weeks, I wouldn't touch again because I had bad experiences in that field, but I would wait. But I think if there is a plateau after 4 or 5 months and it's the same, I think the surgery might be an option.
Thanks, Mohammed. Lawrence, we got a question from you or a comment?
Thanks, Kieran. Good to see you all. A number of comments, actually, and some suggestions. I think probably the key message, which everyone on the call has agreed with, is that you shouldn't intervene at 4 weeks after the injury, which is actually a very common practice across the continent. A lot of people will take these kids, a lot of kids with supracondylar fractures will only present to a hospital at about 3 or 4 weeks after the injury. That's extremely common across Africa. And often they will get taken to theatre for an open reduction. And there's an extremely high risk of getting significant stiffness from myositis ossificans. So all of you the size of the deformity, which plane the deformity is, and the age of the child. And so this is a very young child, so the remodeling is potentially going to happen. Whereas if a child with a supracondylar fracture at the age of 7 or 8 comes, perhaps they won't remodel so well. And then this child has 3 deformities. They have the sagittal plane deformity, which is affecting their range of motion. They have the cubitus varus, and they have a rotational deformity as well, which you mentioned, Mohammed, and often people forget about the rotational deformity. The sagittal plane deformity will probably improve with time because it's in the range of motion of the joint, but also that bony bump on the anterior surface will gradually grow away from the joint towards the diaphysis. And so that restriction of elbow range of motion probably will improve with time, whereas the cubitus varus might not. Your lateral approach for these is a good approach for these more mild deformities. When you get very severe deformities, then sometimes you need to do a posterior approach or a dual approach because the ulnar nerve has to be decompressed as well. One final point, I had a talk from Peter Stevens, who invented the 8-plate recently, and he shows some pictures of putting an 8-plate on the left side of the distal humerus to correct cubitus varus with guided growth. And I wondered if anyone on the call has tried that, because like next time I get a case like this, I'm going to consider doing guided growth instead of an osteotomy. And I wondered if anyone else has thought about that.
Good question. Any comments from the rest of the faculty?
Okay, I think that Lawrence is kind of summarized the problems associated with this particular deformity or injury. I've thought about using the 8-plate for cubitus varus, but I'm kind of afraid because usually the growth plate there is not very clear on fluoroscopy. So I don't know where my center will be, where my proximal screw will be, and so on. But it's an interesting one. I'm sure I'd like to read his paper and see whether his surgical approach is discussed in that paper. But I've thought about it before. All right. And I also agree with the fact that the hyperextension is within the range of motion in the elbow. We know that there's especially because the bump, but the bump is more from the rotational component of the injury than the hyperextension. So we are luckier here because I think that we tend to see them a bit earlier than maybe a place where there's war and instability. So I think that he's done a good job. I wanted him to show the post-operative X-rays, both the AP and the lateral. Okay. Thank you very much. It looks very good.
Mohammed, this is a great case. Excellent job. And I just want to re-emphasize some of Dr. Wicks's comments that usually in this deformity that, the sagittal plane will usually remodel because like Dr. Wick said, it was in the plane of motion of the fracture. But can you go to the pre-op AP? So I just want to make sure that people can recognize the varus deformity. So if you look at the Ballman's angle, if you look at your Ballman's angle, right, so it's over 90 degrees, right, because where the capitellum is and the apophysis there, it's completely flat, right? And you're typically expecting a Ballman's angle of about 75 degrees. And so just sometimes people don't recognize this when they're looking at this in the first place, whenever a child comes to casualty with an acute fracture. And so sometimes people let this go and they don't pin it, and then this is what can happen. And it's also important to recognize your Ballman's angle in terms of your preoperative planning so that you can identify what type of correction you need to achieve.
Appreciate it.
Amanda, are you able to use your annotation to draw out the Bowman's angle for us? Oh, someone's doing it.
Someone do it for me, please. I'm not that great with the technology.
No, but that's fine. Why don't we just have our last comment, please, from Dr. Tucker. I think you've raised your hand. and then we'll move on to the next case if you guys don't mind. Great case, excellent conversation. Go ahead, please, Dr. Tucker.
Thanks, Kiran. Thanks, Dr. Mohammed. That is a very common thing that you see, and I used to see back in my old life. So some of the points that are brought out are very, very pertinent. I just wanted to make a quick comment on the 8-plate growth modulation. I would be a little bit careful with the 8-plate because, as has been pointed out, 20% only of the growth of the humerus happens distally. And depending on the magnitude of deformity and the age of the patient, you may not have enough steam in that growth plate. So if you want to try it, number one, think about who the best patient for that would be. And number two is if you do it on a very young patient, then you also have to think of whether or not they're going to be able to follow up with you to potentially have the hardware taken out at some point. So just a couple words of caution with 8 plates. I think it's a very simple procedure, and it's a lovely little thing that we use for many, 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 many applications, but with a little bit of caution. Thanks.
Thanks, Merid. Appreciate it. Okay, well, for the purposes of time, let's move on to the next presentation. Arsène, are you ready to go?
Thank you, guys. I'm going to stop sharing.
Thank you, Mohammed. Excellent presentation. Great discussion all. Thank you.
Yes, I'm ready.
All right. Please go ahead and share your slides and take it away.
Okay.
And Arsène, if you could just do me a favor and keep the presentation to 10 minutes or less, that would be great, so we leave time for discussion.
Okay. Okay. Good morning, everybody. My name is Arsène Junior Ifrène. I'm working at Justinian University Hospital, Haiti, and it's a pleasure for me to be with you this morning and to present a case based on blunt deformity complicated by septic arthritis. For this presentation, we have two objectives. The first one will be to share our experiences in the management of limb deformity. And the second one will be to motivate young orthopedic surgeons working in conditions with limited resources. My patient is 11 years old. She is a female patient, obese, with functional limitation, intermittent fever, ledger pain, increase in left knee volume, and varus deformity of the left knee. Their relatives said that she benefited from deformity correction surgery dating back 3 years. Unfortunately, after surgery, the left knee became infected and the deformity is becoming worse. Examination, cell sign was positive, and we had an X-ray, but with really poor quality. But we decided at the same time to perform an ultracentesis where we find 18 cc of pus. Specimen for secretion culture and antibiogram was taken. Other lab tests were okay. And antibioprophylaxis with ceftriaxone. We drain and wash the knee. And we, at the same time, we began, after surgery, we began with antibiotics, ceftriaxone and metronidazole, but adult doses. When culture and antibiogram available, so, but after 20 days, staph was positive, Staph aureus, and for the antibiogram, we have to give her TMS, she's sensible to TMS. 4 months later, CRP negative and other labs okay. So we got this X-rays. This is for the pelvis. This is the 2 femurs. And here we are with the knees, with the blunt deformities. So this is the leg. And here is the first picture that we take, okay, after 4 months from the first surgery, when we join the knee and we watch the knee. This is in front, this is the back side, lateral, and we plan to do the second surgery to try to do the correction. So first we go to the left side, the worst one, and we did the osteotomy of the fibula, and we did a double osteotomy of the proximal tibia. Okay, and for doing that, we use a double approach, lateral and medial of the knee. So this is the X-ray after our surgery. But 6 weeks post-surgery, she came back with purulent secretion at the surgical scale, intermittent fever one more time, and we did another culture. We ordered another culture where we find one more time Staph aureus and sulfapyrin. So everything was okay with this. And unfortunately, 3 months later, she felt and she get a fracture, a femoral distal fracture at the same side. So one more time, we have to go back to the operating room and we prepare her for that. So in this case, we decided to put a nail, a sign nail. Okay, so that was the result after this surgery. So 1 year post-op, this is our outcome. This is the backside, lateral, and this is our hospital. Thank you very much.
Thanks, Arsène. Could you go back to the preoperative x-rays? To start, I'd like to invite Sanjeev and Amanda maybe to make some comments on this case.
Okay.
Sanjeev, you want to go first?
No, Amanda can go first. Amanda, go for it.
Thank you. So if I want to make sure I'm correct that this patient had an intervention when she was maybe toddler age for her Ginoverum, is that correct?
Mm-hmm.
Yes.
Yeah.
And then there was a recurrence and it's complicated by infection.
Mm-hmm.
Okay. So when you look at her x-rays, you can see that she has bilateral involvement, but focusing on her left side, which is on our right of the screen, you can see that she has distal femur valgus and proximal tibia varus, which is very common with infantile Blounts disease. And you can see that there's depression of the medial plateau, as well as probably a physeal bar. And so at this point in time, your goals, and I suspect she probably has a varus thrust when she walks based on your clinical images. But my biggest concern is not the deformity, it's in the infection. And so whenever you're dealing with a chronic osteomyelitis, you have to be very thorough in your debridement and make sure that there's no residual infection before you think about pursuing further deformity correction. So when you pursued your operative irrigation debridements, how did you approach it?
Okay, so the first one, I try to face the infection or the sepsis arthritis and to avoid to a septicemia. Okay, but after 4 months, I get a CRP, and the CRP was negative. There's no pain, there's no push in the near. So I decided at this time to do the osteotomy. But as you said, the big concern is the infection, and now she's well. Okay, there's no infection sign, but we continue to with her and to with the follow-up. So the big concern is really the infection, but we try to control this. Okay.
And I think that's an excellent approach to controlling infection, is that you always want to make sure that you have confirmatory laboratory results to ensure that there is no residual infection by getting a CRP, which is actually not available in a lot of centers, and an ESR and a white blood cell count. My other question is, how has her nutritional status been?
Okay. So this is another big problem. So we have no nutritionist available, and and our weight is increases. So we try we to give to talk to a relative, and we try to convince her, okay, to and give a guide to try to control the situation. But this is another big problem in this case, but we have no one that can help us in this sense. Okay. So
that's something that I've found that's very common in treating some of the low-income population I take care of in the United States as well, is that we have a saying that you can be undernourished but overfed. And so people are getting processed carbohydrates, which add to the weight, but often does not add to the nutrition that people need. So you'll often find children have low vitamin D levels, even if you're in a southern environment, which can often complicate bone healing.
Yeah. Okay. Thank you.
Yeah.
Mohammed, did you have a point that you wanted? Oh, sorry, Sanjeev.
No. Let him go first, please.
Thank you. Thank you, Arsène, for this great case. Appreciate your work. I just have a question. With this infection, and you tried your best, but as you know, that the bone infection is always tricky.
Yeah.
Did you think about a laser or something external?
Thank you for this wonderful question. So first thing, we think about ELISA of TSF, but we have no TSF in ELISA of available. So that's mean we have to use what is available. That's why we decided first to face the infection, and then to do the correction, okay, with our plaque. So that's why.
Can you please pull up your plate that you put in, your post-op x-rays? And Sanjeev, please go ahead. I'm sorry. I can't.
No, I mean, a lot of good points here. So my first question is, when you went in and washed the knee, two things. One, what was the status of the cartilage in the proximal tibia? And number two, did you extend down to the metaphysis and see, or drill the metaphysis to see if there was a component of osteomyelitis as well?
Okay. Thank you for the question. When I joined on the first time, so the post I just find it under the joint. Okay, when I drill to the metaphysis, okay, everything was okay. So that's why we just wash this we just close and we just waited for the culture, and after the culture we try to put the exact antibiotic, and that's why we face this situation. But we have no hemoculture available, but secretion culture, the purulent secretion culture was available, and that's why we face it.
Yeah. No, I think you followed the right steps. And I mean, it's unfortunate and it's a little unusual to have septic arthritis and then followed with a second infection. And then, just like was pointed out, let's go to the X-ray, your post-op. And can you walk us through what was your approach? How did you approach it? How did you do the osteotomy?
Okay.
And why did
Yes.
you choose a plate, the kind that you put in there?
Yeah. Okay. Thank you. So for the approach, we first do a lateral approach, okay, and then we do a medial approach. So we have no CM available. So before this, we just get a minimal incision in front of the fibula to make a first osteotomy on the fibula. Okay, but for the tibia, proximal tibia, okay, we plan first the osteotomy, and then with the two approaches, we go to the proximal part to do the double osteotomy, and then we try to get the access, and we use this. Unfortunately, we have all the hardware, so we just use this plate, and we that is a tibial plate, a platotibial plate. We just use it, and with screw 4.5, okay, we just use it, and we ask air to to take late wood bearing, and like that we face this case. So that's
And
why.
then how did you do your proximal osteotomy? And did you use any bone graft for that?
Uh, I didn't use, but I didn't use, but everything. Now the the fracture site is acceptable. So I didn't use bone graft.
Yeah. So, I mean, and again, great effort. And, it's unfortunate it got infected again. But, a couple of things, because as you saw in the pre-op x-rays, there was the plateau depression medially, right? So if you're
Yeah.
going to elevate it, and I think that was probably your attempt to, right, elevate that medial plateau, then it does need some structural support. And if you are going to do the two-level osteotomy, and I'm assuming you did a closing wedge for your second osteotomy. You took some bone out, right? For your second osteotomy in the metaphysis.
Yeah.
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 So you could potentially a combination of using that bone that you took out plus the fibula that you may have resected. You could actually have used that as a strut to support your medial plateau. And then in general, if you're going to, do an osteotomy medially based, just biomechanically, it would make a little bit, a biomechanical sense to put some hardware on the medial side to support that construct, right? And then final thing, and I'm sure you must have done it, but a case like this, big leg, big correction, a prophylactic anterior compartment fasciotomy, and maybe putting a post-op drain. So
Yeah.
those, and then how did you do some of that stuff? The
Yes.
fasciotomy, yeah.
Yeah. I did it after surgery. I didn't close the fascia. Okay. I didn't close the fascia. Yeah.
What was,
And
yes
I
or
put
no? You
also,
closed it?
no, I
Closed
didn't
it?
close it.
Oh,
No,
good.
I didn't
Perfect.
close it.
Perfect. Yeah.
And I put a drain to, okay,
Yeah.
to,
Perfect.
okay.
Yeah. Very good. Thank you.
Thank you.
Excellent. So, Dr. Ilyas, Dr. Tucker, we have some comments from you, and then we'll move to the next case. Dr. Ilyas, please, you first.
Yeah, nicely done, nicely managed case, but I have an opinion. in these patients with severe deformities, already history of infection, I think Ilizarov is the way to go. And usually in developing parts, you do get in, because the theater settings are not very good. You do get infections, but in the history of infection, if you're literally opening up whole of the leg to apply a plate, do a very big osteotomy, the soft tissue dissection is too much. You frequently end up with these complications. So I think Ilizarov is a very good way. And locally made Ilizarov device doesn't cost much. The ones that we have cost about $100. So this is a good way. If this case would have been done by doing an percutaneous osteotomy, would have gradually opened up the medial side, maybe did a hemi-plateau elevation using Ilizarov as well. And the distraction histogenesis, it increases the vascularity and it deals with the infection as well. So in these cases, I think Ilizarov is the best way to treat the patients.
Okay, thank you. As you say, you say Ilizarov is the best one, or TSF, but for this moment, we have no Ilizarov available in our center, and we have no TSF available. So that's why we decided to use, with our limited resources, what is there, and that's why we try to face this situation. So
Forgive my ignorance as a non-pediatric surgeon here, but especially in the setting of an infection, prior infection, I mean, that seems to have been eradicated. What about just K-wires to hold and then casting to reinforce? Is that ever an option? Amanda, you're shaking your head furiously. Yeah, go ahead. Tell me why.
I think it's an option in a patient with a smaller body habitus, but not in someone with this body habitus, the pins would break.
Makes sense. All right, awesome.
I saw once a patient with A-wires and casts, and when the cast was taken out, there were literally maggots coming out from the wound. So with patients with big soft tissue cover, I think that's a guaranteed disaster. I would never do that in a patient like this.
Well,
good.
Can I counter that? Can I counter that? I know Merid wants to say something too. But, to your point, I think limited K-wire fixation that's buried under the skin and, multiple wires, thick wires is not a bad way if you don't have screws and fancy plates and you want to minimize hardware. So I wouldn't totally, get rid of that idea. I think strategically placed internal K-wires or Steinman pins is still an option, especially if you don't have access to fluoroscopy and fancy screws, etc. So,
Mihir, any comments?
Yeah, so a couple quick things. One is, I think dealing with the infection first is absolutely the right way to go. Two is external fixation would have been preferable had it been available, but if it was not available, then you do what you need to do. Just talking about the deformities and their correction and some of the things to potentially think about. We've talked about the medial physeal bar and the hemiplateau depression secondary to that. This girl is old enough, so she's 11, so probably not a whole lot of growth remaining on that lateral growth plate. But if you did have growth remaining on the lateral growth plate, then shutting down that lateral growth plate to minimize recurrence of the deformity is something to consider. Two is when we are correcting these deformities away from the apex of the deformity, there needs to be a little bit of translation of the fragments to centralize a mechanical axis as best as we possibly can, which is where the plate sometimes becomes a bit of a challenge because it doesn't quite allow you that translation of the distal fragment. So something else to think about in that deformity correction. And then the last thing I also wanted to get everybody's comments on is with that distal femur fracture, I'm hoping that it was a significant traumatic event that led to the fracture and wasn't anything through infected bone. But the question that I had was, how comfortable are you with the knee being sterile at that point for you to be able to put in a retrograde sine nail through the knee into the femur? How do you confirm that you're going to be safe there. So that's another thing to kind of think about.
I can thank you for the comment and this question. So this is a really odd situation, but we tried to face it, and now she's using a knee, and she got a functional knee, and as I said, we continue, we keep on the follow-up, and the evolution, the outcome is really well. So we just try to face this situation, and as you also said, we just use as we the hardware available just to solve the problem. But for the knee, for this moment, everything is okay, and she has a functional knee. Okay.
No, that's great. Yeah, these are tough problems, right? You have multifocal issues to deal with here, plus the infection to make life even more complicated. So nicely done. One last question. What are her leg lengths like now? Because the left side obviously was shorter to start with. And with all of our interventions, she's probably even shorter. So, you know, another thing to think about is the leg lengths and how to manage those over time.
Okay. The left side is a little shorter than the other one. Maybe now 3.5 or 4 centimeter. Okay, but she's well. She work. Okay, and she can play. And she's doing all the activities. So that's why, as I said, we have to continue with the follow-up, and we continue to face the challenge, the situation. But as I said, we try to make our best, okay, and we try to give our best just to try to save this life. Okay.
Thank you very much for sharing. That was a challenging case at multiple levels, and I think the end looks pretty good. So congratulations.
Thank you.
Yeah,
Thank you very much.
Thanks, Arsène. Really tough case presentation, very well presented and well managed, and despite all the challenges that you experienced. And thank you, faculty, for all the excellent learning points. I definitely learned a lot. I think for the interest of time, we'll move on. Dr. Leul, Merid, if you're on the line, I don't know if you had any comments for this case, but certainly we'd like to give you the podium now to present your case, if you would like to.
Okay, thank you so much. I will straight go to my presentation.
Great. So you are now a co-host. You should be able to share your slides. Please go ahead.
Okay. Thank you.
Arsène, thank you so much. Excellent presentation.
Thank you.
And just a reminder to all of our participants and to our faculty, we have a Q&A and a chat open. If you'd like to send messages on the chat, faculty members, please do keep an eye on that to take a look. Dr. Leul, can you make it full screen for us?
Are you able to see it now?
Yeah, we can see it perfectly. Please go ahead.
Okay. So my name is Leul Merid. I'm a pediatric orthopedic surgeon from Hargeisa, Somaliland. So my case is going to be on Coxia Brevia. So we'll try to see a case of femoral neck lengthening using the triple osteotomy of Moshe. So this Coxia Brevia, this pathology results from premature closure of the epiphyseal plate on the capital epiphysis. So the deformity results from differential growth since there is a growth arrest on the epiphyseal growth plate, but the growth plate on the greater trochanter is growing, so there will be differential growth that will drive in the characteristic deformity with short neck, flattened, and big knee head, as well as this leg length discrepancy. So this pathology can result from those conditions that affect this growth plate, resulting in like like Pertus disease, developmental dysplasia, infection, could be secondary to trauma, idiopathic. So all those conditions will result in growth arrest and causing differential growth in the characteristic deformity. So this pathology will result in shortening of both the lower limb as well as the neck, with overgrowth and proximal migration of the trochanter that will have effect on the lever arm system, and that will weaken also the hip abductors. So this will result in characteristic triangular gait with abductor large, pain and other clinical manifestation resulting in the differential growth arrest. So there are a lot of procedures described to correct this characteristic deformity. So in 1980, Erwin Morshill presented a femoral neck lengthening osteotomy. So the goal of surgery is restoring this normal anatomy and restoring this hip biomechanics. So to do so, what Morshill described in his classic literature was it's a triple osteotomy, it's a triple horizontal osteotomy. So parallel osteotomy, the first osteotomy is on the greater trochanter, that will resulting in distalizing the greater trochanter. And the second cut is going to be the moving fragment that will be placed in between. And the third one is a parallel in the inferior aspect of the neck that will translate the lateral, as you can see it on the image. So this is going to be the first cut. And this is the middle segment is a moving fragment, as well as the subtrochanteric or the parallel. Another third cut is going to translate the lateral, resulting in all those try to correct all those characteristic pathoanatomies. So usually these patients with Coxia Brevia present with pain or limping, characteristic abductor lurch. Because of this abductor insufficiency, they will have characteristic abductor lurch. So this is our case. He is a 15-year-old male who present with limping, pain, and restricted range of movement of the left hip. So he has previously history of trauma. Otherwise, he denied any other incidents. So as you can see from the X-ray, the right side has well-formed head, neck, as well as normal neck shaft angle with trochanteric Abdulal as well as center trochanteric distance. All those radiographic parameters normal on the right side. But as you can see on the left side, there is a short neck with a trochanteric capital as well as the center trochanteric distance with a neck shaft angle in varus. So this was his pre-op gait. So characteristic, he has shortening on the left side with abductor lurch, with painful and restricted range of movement. So using the previous triple osteotomy of Morshill, we take him to the OR. So we put under fluoroscopic, I have the fluoroscopic X-ray. So I put guide wires on for those characteristic 3 cuts, and I navigated using fluoroscopy. It is proper placement using C-arm fluoroscopy on AP and lateral X-rays. So once I get the proper placement, I do my first cut. So my first cut was this is a cut that I'm going to for distalizing the trochanter to retention the abductor, so that will maintain, correct the lever arm as well as correct the trenolumbar gait. So using the lateral approach, subvastus elevation, identify under fluoroscopic navigation, put the K-wires, checking it on AP lateral and do the first cut. So this is the first cut for the trochanter. So the second cut is for the moving fragment. So it's similar, I routinely use guide wire insertion, lift it all the way out, take it out, and try to tunnel it on the angle plate. This is an image that shows inserting this, creating a tunnel and inserting the middle or the moving fragment that will effectively lateralize the shaft as well as the distalized trochanter. So this is the second cut, and the third cut was for the seating chisel for placement of this angle plate. So, and the third one was on the inferior aspect, so that the shaft can be lateralized. So this is the third cut. So once I do my third cut, I insert the seating chisel. Because the second cut on the second fragment, the moving fragment, is already mounted on the angle plate Once I insert it, then I try to lateralize the shaft. This is how you can. And finally, I try to distalize greater trochanter and fix it with 2 screws. So this is this is the final after lateralizing, seating, chisel placement with a middle moving fragment with distalizing and trochanteric fixation. So we can compare the radiographic parameters that we correct. The tip, you can compare the tip of the trochanter, and this is articular. So articulotrochanteric distance initially was on the negative, but here you can see the articulotrochanteric distance is perfectly corrected. So the second parameter is going to be centrotrochanteric distance. Ideally, they should be collinear. In this pre-op image, you can see, but on the post-control X-ray, it's nicely corrected. This is the tip of the trochanter, and this is the center of the head. So the centrotrochanteric distance is restituted, as well as the third radiographic parameters that I checked was on the neck shaft angle. So the neck shaft angle here was around 85 degrees, but here it's under 30 degrees, which is a target or the goal for the neck shaft angle comparing the contralateral. So this is a final on imaging. And this is a patient after 2 years and 6 months follow-up. He came for implant removal. This is a recent imaging.
Thank you, Dr. Leul. Any comments from maybe Mihir, since you gave a great lecture on hip. Any comments on this case?
I think this is very nicely done. I think the Morsher osteotomy is an extremely useful tool to not only get the abductor lever arm more normalized, but also improve the limb lengths. As you've very nicely shown, Dr. Merid, that looks very nice. With the coxa vara deformity, with the short femoral neck or coxa brevis, there's a couple things to think about. Number one is, what does the head and the acetabular relationship look like? If those match nicely, then it makes perfect sense for us to then be able to do a morsure without necessarily changing that relationship. However, in some cases, there is a good bit of varus where you really have the top of the neck very, very close to the acetabulum. So the traditional morsure did not change the neck shaft angle all that much because the blade plate goes in right into the middle of the neck, and then your 2 cuts are parallel to that. I think what you've done very beautifully, actually, is a slight modification where you put in your blade plate at a little bit of a varus angle so that when you corrected it, you got that neck shaft angle restored also. So I think that was a very nice maneuver on your part there. So what that did was it helped kind of restore the relationship of the femoral head to the acetabulum instead of leaving it down in the varus position. Even with that, sometimes you still will end up with a little bit of a bump on that superolateral corner, which you have. As long as it doesn't impede motion, it's not a problem. One of the things to be careful about with the morsure is with that second cut. So you take your first cut up the trochanter and leave that trochanter with the abductors attached to it. And then the second cut is going flush with that superior surface of the neck. That's where you need to be a little bit careful because that's where the vascularity of the femoral head comes in. So how did you plan that cut? Because it looks really nice and obviously you don't have any vascular issues. So it'd be nice for everybody to get a sense of how to plan that cut and how you executed that. Would you mind commenting on that, Dr. Merid?
Yeah, and Dr. Leul, could you pull up your slides again, just so that we can see that X-ray, so we know exactly what Mihir's talking about?
Yeah, sure, I will. So this is a second cut.
Oh, I don't think we see. We don't see your slides.
You don't see my slides? Okay, let me adjust it. How about now? Are you
Yeah.
able to see now?
They're coming, yeah. They're loading. Yep, great, thank you.
So this is what we are discussing. So usually for hip osteotomies, I do a number of hips osteotomies for indication of SCIFI with modified Dan osteotomy with surgical Gans hip dislocation. So I routinely first identify the circulation, the lateral cutaneous, the artery. I try to identify first before I do my osteotomies. Yeah, that's my thing. I do a number of hips for this surgical hip dislocation to correct SCIFI and other pathologies. So I routinely first go there, identify the circulation, get it out of the field, and do my osteotomies.
Great. I'm assuming, though, this was not done using a surgical dislocation approach, right? This is just a standard lateral approach.
This specific case is not for surgical hip dislocations. Yeah.
Wonderful. Sanjeev?
Yeah, thanks, Mayor. It's a great case, seriously. I don't think, well, I can tell for myself, I'm not as skilled as you in terms of, performing this so accurately. So for other people on the call, what other options do you have besides a Morsher? And I'm just thinking of options such as just doing a relative neck lengthening, distalizing the trochanter, just doing valgus osteotomy of the proximal femur. We've written about doing it percutaneously with a simple X-fix. So what would you advise other people on the call who may not be as skilled as you?
So there are a number of procedures actually described to correct this Coxia brevia. The simplest would be the two osteotomies would be easier than the triple osteotomies. Just distalizing the trochanter with a subtroch osteotomy and valgizing will do the job, really. I've done a number of cases in the more or less, even I tried to review systematic review, trying to compare both these triple osteotomies versus the double osteotomies. They have comparably good functional outcomes. Yeah. The most important trick here is fixation regarding to the greater trochanter. That is the main point for failure regarding these fixations. Once we can get a good, strong purchasing fixation of the trochanter, they will do the job. That's my experience.
Yep, thank you.
And most importantly, as the doctor tried to mention, circulation, knowing the anatomy of the arterial supply of the head is very critical pertaining for all hip surgeries, really. That is a take-home message I want to emphasize.
And if you were to stage it, or if you were to do just one or the other, distalizing the troch versus a valgus osteotomy, do you have a preference in terms of the order, or which is better to start with if you weren't going to do both together? Let's say somebody wasn't skilled enough to do both the distalization of the trochanter and the valgus osteotomy because of too many moving parts. What would you suggest be the first thing to do, let's say for a patient with these x-rays?
Yeah, I have never tried the sequential staged procedure for those, but I would, if I am obliged, I would prefer first distalizing the trochanter, and later on, once the trochanter has healed, I can valgize it always.
Yeah, that makes sense. Thank you.
Lawrence, did you want to jump in?
Thank you. Yeah, just on the discussion between a Morsher and doing a valgus osteotomy, the point's already been raised that you need to look at the relationship between the acetabulum and the femoral head. And it may be in some cases that if you do a valgus osteotomy, you may change it from a congruent joint to an incongruent joint, and you may make the patient worse and cause intra-articular hip pain. And so it really, like Amanda's talk about deformity correction, it's all about planning. And so if you've got a congruent hip joint, but an incongruent shape to the femoral head, by doing a valgus osteotomy, you may make it actually worse. Does that make sense?
Yeah, absolutely. Absolutely, because there are no certain specific indication for correcting these Coxia Brevia deformities, apart from those radiographic and mechanical parameters. But one of the contraindications to do this valgizing, corrective osteotomy is osteoarthritis. So this incongruent hip anatomies are part and parcel for this osteoarthritis. So I wouldn't go for if it hampers this incongruent article for valgizing osteotomy. That would be my contraindications next to osteoarthritis.
So if you have fluoroscopy available, the first thing I would always do is one of these cases is actually do an EUA and screen the hip in different positions to see what makes the hip joint most congruent. And if the hip is most congruent with the hip adducted, that indicates that maybe a valgus osteotomy might be better than a mortia. But actually, if the hip is most congruent with the leg in a neutral position, then a mortia is more appropriate. One thing I've never understood with the mortia, though, is why you have to have the moving fragment. So I don't actually do that when I do it. I just make 2 cuts. So I don't have a separate moving fragment that comes out and I have to put back in. I just take a larger piece of the greater trochanter and then I just fix that. I make a space for it and just fix it. So I actually only make 2 cuts when I do a relative neck lengthening rather than 3 cuts. I'd be grateful to know if there's any reason why I have to have a moving fragment. But it seems to complicate things for me, and I would rather just make 2 cuts and larger, greater trochanter fragment to fix.
Any comments related to that one, Mihir and Saad?
Yeah, I think.
Yeah,
Go ahead,
ideally, what it does is it will increase the surface area to distalize the shaft and the other is you will have a good purchase for fixing the distalized greater trochanter. That increase effective lengthening. That will allow you increase surface area for healing, increase for lateralizing the shaft, as well as getting a good purchase for distal fixation of the distalized trochanter. I hope, I guess. You can add on it.
Okay. What I've managed to do is just make a space for it, and so I've managed to put the whole fragment into that space to allow for the relative lengthening. I don't know. Maybe I haven't done enough to know the ins and outs of it.
Lawrence, I believe that the rationale there is you want your fixation to stand off, and depending on what you're using, if you're using a blade plate, it's not as much of an issue because it's not going to cut in. But if you're using anything else, then you need a spacer there to keep that fragment long enough to lateralize the distal fragment. And also, if you're lateralizing the distal fragment quite a bit, then it increases your bony surface area for union. And I think that's kind of what the thought process behind it is for the most part. But I agree with you that if you're not really aiming for too much of lateralization, then it's perfectly fine to take a large trochanteric piece and then put it back down. One quick thing, I think what you very nicely also pointed out is the adduction, abduction functional views to try and figure out what's going to be the best osteotomy. With the congruity best in adduction, adduction, valgus seems to be the right thing to do. When you're doing those, the one thing to look out for also is what is the acetabulum like. So if the acetabulum is sloping and dysplastic with a significant valgusization, one does need to be a little bit careful about potentially hip instability. So in that situation, you might want to think about doing something to the acetabular side as well. So look at the femur, but don't disregard the acetabulum. That's the message.
Yeah, I would agree with that.
Yeah, I would like to add a couple of comments. Very nicely done case. But in patients like this, as a part of pre-operative workup, I usually add a full adduction view and an abduction view. Because if you get a full adduction view, then because you're valgifying it, you don't want to make your hip incongruent in doing so. And another option is you need to see are there any osteophytes around so that they might cause any impingement. So a lateral view, it can be a frog lateral view or a Suji-Okas view, anything. So as a pre-operative planning, I would really like to see both AP and lateral and look for any osteophytes. and full adduction and abduction views. Plus, I think this osteotomy is very nice, but since it has Coxia vera as well, so I think if you first valgify it, and you don't, there's a technique, no wedge technique, in which you do an end to side valgification. It's a really nice procedure. You can do with a mini DHS or a blade plate and correct the ankle, because that's gonna tension your abductors, that's gonna bring down the trochanter as well. So in my opinion, if you want to do one of these two procedures, like it was discussed before, I think we should first try the valgification, because it's gonna deal with a lot of stuff as well.
Yeah. And often in these cases, it's not just adduction that makes the joint more congruent, it's adduction and flexion. So it's not just a valgus, often it's a valgus extension osteotomy, isn't it, that makes the joint more congruent.
There are a couple of good questions in the Q&A I thought we would ask before we move on to the next case. Message from Mukwaka Oda. Great achievement, Dr. Merrill. 2 questions. Could you please point out the material used to do the osteotomy? And if fluoroscopy is not available, what planning should be done, or rather what needs to be done for the case?
Yeah, for my osteotomies, I use low power multiple drill as well as power saw. I have fluoroscopy. I don't know. It will be very difficult to do such kind of osteotomies in the absence of fluoroscopy, really. I wouldn't suggest to do it without fluoroscopy.
Yeah. It seems like it's a very essential tool for this kind of case.
Yeah.
Okay, well, just for the interest of time, why don't we move on to our next case presentation, if you guys don't mind. Dr. Sabir Khan, would you like to pull up your presentation next? Dr. Leul, fantastic case presentation. Thank you so much. And glad that we could cover.
Thank you so much.
Yeah.
Thank you so much for giving us this opportunity.
Oh, of course. It's our pleasure. Thank you all.
Thank you. Thank you.
Thank you, sir.
Sabir, are you able to pull up your case presentation?
Yeah. Can you see my screen?
1 second. Let me switch to yours. Yep, we can see it. Everybody else good? Go ahead, Sabir, please.
Yeah. Hello, everyone. I'm Dr. Sabir Khan, resident orthopedic and spine surgeon from Gurgi Trust Teaching Hospital, Lahore, Pakistan. I'll be presenting a case of Windswept deformity of the lower limb. This is only one case, so I'll be presenting due to shortage of time. So this is the pre-op image of the patient that presented to us. This is, I'll brief about the short history of the patient. This 20-year-old male presented to...
Sabir, your screen is not visible. I think the right presentation is on.
It's visible for me. Can anybody, is anybody else having trouble seeing it?
No, we can see. We can
There are
see.
2 tabs, so you might need to click on his tab for the Zoom.
Oh yeah, Leul, can you stop sharing your slides maybe?
He has to stop sharing, yeah.
No, it's okay. No, it's okay. Thank you.
Okay.
Can you see?
It's unshared.
So the screen, on the screen there will be a gentleman, 20-year-old gentleman presented to outpatient with complaint of leg deformity and difficulty to walk. He has this deformity since childhood, which increases with time. He had a normal birth history and had done all his scheduled vaccinations. He went to quacks for the for this deformity initially in childhood, but and general orthopedic surgeon, but they all counseled him that we will do the wait and watch technique as usually, and we will correct the deformity once it reaches to the skeletal maturity, as it is a very common practice in Pakistan due to lack of orthopedic specialty in the periphery of Pakistan, that usually the general orthopedic surgeon, they ask the patient to wait and watch and till the skeletal maturity, and they will then reduce or correct the deformity. So this gentleman, 20 years old, presented to us at very lately. And presentation, he had a normal range of motion from 0 to 160 degree, 0 to 160 degree, and there was his metabolic profile was normal, and had skeleton survey was also normal. So on pre-op radiology, his distal femoral angle was 48 degree, and on PTA was 93 degree on the right side, and on the left side there was varus deformity. So what we did, we planned the patient one time. We planned the patient for corrective surgery. We usually do one leg at a time, and both femur and tibia in the same go. So we approach the patient from the right side, and we did the valgus knee first, valgus side first, and we had options of external fixator, correction of the deformity with external fixator like Alizarov, the plate fixations, but we opted for the minimal invasive technique, the intramedullary interlocking nail with polar screw and minimal invasive osteotomies, percutaneous osteotomies to correct the deformity. So we initially planned the patient, and we mark our polar screw sites on the radiology, and these are the polar screw sites in the AP radiograph and then the lateral radiograph. So perioperatively, when we take the image must be in true AP view, and we guide ourselves with that the 81 degree angle of the distal femoral angle to correct the deformity, and guide the first polar screw to be placed in the right direction. So initially, for guiding, we put a K-wire and just guide the first polar screw on the lateral aspect, and then another screw from the lateral aspect in the posterior direction. Then we put a screw on the medial side to avoid toggling of the reamer. And after that, we insert the reamer and insert the reamer and insert the reamer in the direction. And when wherever it touches the cortex, we did the osteotomy at that site percutaneously and then we just joystick the deformity to insert the nail in the proximal segment. Insert the reamer in the proximal segment initially, and then proceed with the correction first. We do as much as osteotomy, percutaneous osteotomies to correct the deformity, and proceed with the reamer, and then after that we insert the nail and in the corrected bone, and then we do the locking. But the important thing is we do locking after correcting the rotational deformity, as there must be a rotational deformity. So the rotational deformity is also corrected with this technique, and the valgus deformity and the procurvatum deformity, which was present, is also corrected. And the procurvatum, and when the procurvatum is corrected, as whenever the reamer touches the cortex, so we do an osteotomy there. So that's the radiograph after 6 months. The union is achieved. There is distal femoral angle is 78 degree, which is quite acceptable, and the distal femoral angle is 82 degrees in this case. So for tibia, we also do the tibia in the same setting, and we do the osteotomy. We do the osteotomy through the infrapatellar. We inserted the nail through the infrapatellar approach, and we do the osteotomies, and inserted the polar screw initially, and after guiding, we do the osteotomies and correct the deformity, and insert the nail, and then locked it in the correct position. And these are the radiograph after 4 months. And these are after 6 months, with the proximal tibia angle is 89 degree, normally restored, and distal tibia angle is 90 degree. So with minimal invasive technique and of osteotomies and small incisions and not disrupting the normal biology of the bone. We do the corrective osteotomies, and the leg is restored, and the normal mechanical and anatomical axis are restored. And the union, as long as regarding the union, it was really good, as we don't disrupt the periosteum much, as the osteotomies was through a small keyhole incision, and so the union was quite good after 6 months, and we achieved the results quite. And this is the department picture led by Professor Ahmed Aziz, and the deformity team is led by Dr. Saied. Thank you so much.
Thank you, Sabir. If you can go back to your preoperative x-rays, that would be great. And Saad, would you like to make the first comment since you were supervising this case?
Yes, sure. Thank you. So, I find this a very convenient way, because in these patients, if you want to correct this deformity by any other way, it's very difficult. But it's multi-apical. There are deformity in both planes. So it's a very convenient way. All you need to do is to direct the nail in the metaphyseal area, and that's it. And rotation gets controlled, and all the deformities get corrected. So it's a very convenient way of dealing with these complex deformities in a very limited resources, because all you need is an intramedullary nail and a C-arm.
And I would highly recommend anybody who hasn't already to please watch Dr. Saad Ilyas's video that's posted on our YouTube channel based on a lecture based on this kind of case. Amanda and Michael, do you have any comments on this case? Would you have done this any differently? Any other methods that you would recommend? Amanda, you want to go first?
Sure, thank you. Well, this case is very elegantly performed. It looks excellent, great result. One thing that I thought was very good about this case is that because they're using a nail to correct the deformity, they used anatomic axis planning as opposed to mechanical axis planning. Because if you are going to correct a deformity with the nail, you have to make sure that you don't require too much obligate translation, so that the nail won't go through the canal. I think the other good consideration they used is that, well, actually my question for you is, how do you judge your correction intraoperatively on the OR table? Do you use a grid? Do you use a bovie cord? What do you use?
It's I don't have a grid, so I use this cautery lead.
Okay.
So I use this, yeah. And the thing that's very important, once we pass a polar screw and you introduce your first reamer, you take a picture on your C-arm and you ask your assistant who's not scrubbed up to take a picture and draw the angle. That reamer has to be at LDFA of as close to 81 as possible. So if it's not there, you just remove your screw, reinsert it. So that's the time-taking part. But once the reamer is at 81 degrees, then all you need to do is a percutaneous osteotomy. Obviously, there's going to be translation there, joystick it and do it. So that's about it.
Another technique that I liked that you used is for the sagittal planning, that you kind of use the soul field technique, where you let your reamer tell you where you need to make your next osteotomy approach. And I think that's sometimes very helpful.
Diaphysis is definitely.
And then my question for you is, what size did you template your nail to be?
Actually, usually in these patients, a union is going to be achieved in about 6 weeks. So it's not a problem with the union. So I just start, even if it's an 8 millimeter nail, I'm not worried about it. So I start with the smallest reamer. Obviously, templating won't be possible here because it's all curved up. So I start with a 6 millimeter reamer, and even an 8 millimeter solid nail is good enough for me. So usually in 8 to 10, that's 8 millimeter or 10 millimeter. That's usually the size of the reamer.
Forgive me for interrupting, but the reason I think that's really important is that often when you're doing these corrections, since you're doing percutaneous osteotomies, you often want to make sure your nail is undersized compared to the femoral canal.
Yeah. So even in adults, 8 millimeters is fine. So I even in a few patients in which I was worried about the canal diameter, I even used, in one patient, I used a humerus nail of 6 millimeter. So in one patient, I had to do that.
And you make them weight bearing as tolerated afterwards, of course.
6 weeks. I allow them weight bearing at 6 weeks. Immediate range of motion exercises and weight bearing at 6 weeks.
I see.
And
All right, great.
usually other leg in at 3 months.
We have Sanjeevam here with their hands up, but I also just wanted to ask Dr. Segbefia, did you want to make any comments before we move on to the other two faculty?
Okay, thank you very much for this presentation. It looks good. I usually would do it as an antegrade procedure, but looking at this now, I mean, the growth plate is fused, so I think that doing the retrograde procedure is also good. Um, I will use the smallest needle available for this, and I'll start with the smallest reamer and stay with just the smallest reamer. I don't even go to the next level. But I like the way you deploy the screws to guide. I think this is something that I will also try going forward. Thank you.
Sanjeev, Mihir, did you guys have some comments to make?
Yeah. Well, Mary, you want to go first, or I'm good? Okay, I'll go. So a couple of things. Well, first, obviously, well executed, nice outcome. Two or three sort of cautionary thing. One is not so much when you're going valgus to varus in the femur, but for the tibia, certainly, you got to think of releasing the peroneal nerve, or being careful in terms of the magnitude of correction. So I don't know if you did a peroneal nerve release proximally or not, but for acute corrections in the proximal tibia, valgus to varus, I think that's something to think about. Plus, maybe do a prophylactic percutaneous anterior compartment fasciotomy.
Yeah,
In terms
that's an excellent point. That's if it's a valgus deformity of more than 20 degrees in the proximal tibia, I would never go acute. It's a sort of cutoff for me because, I have ended up I did once in a patient with genu valgum in proximal tibia, and I ended up with foot drop. So usually if the deformity is at one point, if the deformity is more than 20 degrees of valgus in proximal tibia, I would never do an acute correction. Yeah. I would apply Lizarov and go gradual. But if it's a multi-apical deformity, when upper tibia is contributing about 7-8 degrees, distal or middle is, then I would do it. But for proximal deformity, if more than 20 degrees, I would never go acute, always gradual.
Yeah. And
Thank you for pointing out.
Yeah. And then, especially when you're doing both femur and tibia, you got to think about the effect on length, right? So if you're doing an acute correction, even in the femur, you're already putting things at a stretch. So I think 20 degrees is an okay number, but even for lesser degrees of valgus proximal tibia, I think it's probably a safe thing to do. And then again, just like with the last case with the morsure, I think it's always good to have, a very, advanced technique, but then always think about what else can people do who are not as skilled as you are. So two things come to mind. One is instead of putting, polar screws first, blocking screws first, you can also do fixator assisted, or even a more simple technique is just put a half pin, take a T-handle chuck, and have your assistant hold it, take a portable X-ray or a fluoro shot, and then commit to your guide wire and reamer. So I think that's another way you could do it. And then, of course, there is this clamshell osteotomy for people who are not very well versed with the fluoroscopy and fixator-assisted nailing, that you just sort of take the mid portion, especially in multi-apical, mid-diaphyseal or diaphyseal deformities, where most of the deformity is not periarticular. You just sort of fillet open the lateral side of the cortex of the femur, and then pass a nail starting at the anatomic point and ending at an anatomic point. So I think that's another good technique for these metabolic and multi-apical deformities, especially in the femur. Right. Nice case.
Yeah. There's one quick question from the audience that I just thought we could answer quickly. Excellent presentation. What is the rationale for not permitting weight bearing until 6 weeks?
I just don't want to take the risk. That's it. Otherwise, theoretically you can do it, but it's a habit. I'm not saying that we can allow weight bearing, but it's a habit. I want to because there are so many osteotomies, especially in the metaphyseal area, both in tibia and femur. So I just want to wait for 6 weeks, nothing else. So I want my patient to focus on his knee range of motion in the first 6 weeks, then I allow them range of motion. That's my rationale. I'm not saying that early range of motion is not right, but that's how I do it.
Great. And then there's some comments here also about like potentially using Ilizarov. I imagine Ilizarov would be quite difficult in the femur.
It will be quite multiple APCs. You'll have to do more than one osteotomies. It will be very difficult to apply an Ilizarov in this patient.
Yeah. Mihir, did you have some comments?
One more thing. Ilizarov, you cannot correct the torsional components with Ilizarov very nicely, because Ilizarov can do everything, but the rotational problems, it's very difficult. So you can correct deformities, but with this technique, very easily you can correct the torsion as well. So that's one point. So it's
great. Good point. Mihir?
Yeah, I was just going to make a couple quick points. I think number one, this is excellently done, respecting a lot of the principles that have been brought out. So nicely done, sir. Two is, when it comes to that peroneal nerve, just like Sanjeev was talking about, you do have a sizable distal femoral deformity and then a proximal tibial deformity. So certainly paying attention to that nerve, potentially doing a decompression would be something to think about. But the comment that I was going to make was hopefully a little bit of a helpful one, because you said that the struggle is in that initial guide wire placement at the 81 degrees. They do have these metal goniometers that you can sterilize and then use intra-op. So that takes away some of that initial guesswork from the guide wire placement, so to speak. So that might be something to consider if that is something that's available or something that can be easily made for you, because those are not hard to even get someone to make. So that might be a useful tool. We use that fairly routinely in these kinds of cases, and it makes life a little bit easier to start with. So, but beautifully done case. Lots of good things for all of us to learn.
Yeah, thank you. Just for the interest of time, I'd like to invite Dr. Dominic Konadu-Yeboah to give our last case presentation. We won't have a lot of time for discussion since we're getting close to the end of the hour, but I think it's a really fantastic case, very interesting, that I hope you'll all enjoy. Thank you all for these amazing cases. Really appreciate it. Dominic, please, go ahead.
Thank you,
for
the opportunity. My name is Dominic Konadu-Yeboah, as mentioned, and the goal of this presentation is to share our experience in the management of a rare congenital lower limb malformation in Ghana, and that is Polymelia. Polymelia is the presence of supernumerary limbs that are attached to a segment of the body. It's a very rare congenital malformation with an incidence of 6 per 10,000 live births. It often has a heterogeneous pathogenesis with incomplete separation of monozygotic twins as the most common etiological factor. It usually occurs in animals, and most of the literature has reported the incidence in animals, but extremely rare in humans. It has been associated with this organization gene, the Maltese organization gene, in terms of its etiology. And when the gene occurs in the homozygous state, it tends to be lethal, and those fetuses do not survive. In the heterozygous state, it has incomplete penetrance with various expression of the phenotype. There are a number of factors that have been associated with the malformations of Polymelia. One of them is the fibroblast growth factor, which has been shown to be responsible for agenesis or cranial bone malformations in children with this abnormality. Polymelia may be classified based on the body region to which the accessory limb is attached. When it's attached to the pelvis, it's called Polymelia. When it's attached to the thorax, it's known as Thoracomelia. When it's attached to the spine, it's called Notomelia, and to the head, it's called Cephalomelia. And most of the time, when the anomaly occurs, it may occur in association with other congenital malformations. It may be part of the vector sequence where the child may have associated cardiac, renal, or esophageal malformations. Now, this was a case of a 5-month-old baby who was delivered by cesarean section at 37 weeks, 3 days gestation. And the cesarean section was performed on account of the mother requesting bilateral tubal ligation. She was a mother of 5 children, and she wanted to opt for sterilization. So she wanted the cesarean section. So the cesarean section was performed at CAF in Kumasi, Ghana. The baby was delivered with a birth weight of 3.7 kilograms, and that baby was found to have multiple malformations. There was no inner orifice. There were some anomalies involving the spine, the eyes, etc. Now, when we delve into the history, the mother of this baby had no exposure to teratogenic agents during pregnancy. She did not have a history of smoking, and no other cause of congenital malformation in pregnancy was identified. It was interesting to the team that this mother had undergone a series of antenatal ultrasonography. Particularly, anomaly scan was done at 26 weeks of gestation, but none of them was able to pick up the malformation in the baby. So this was the baby, as you can see on this slide. The baby has 6 limbs, 2 upper limbs and 4 lower limbs. There was a myelomeningocele at the lumbosacral spine. And if you look at the lower limbs, the power in the most lateral ones was 5/5, and that in the most medial limbs was reduced, 1/5. And the child had 2 pelvises. Both had phenotypic female external genitalia. And if you look at it closely, the right hemipelvis had a vestigial external genitalia. The left hemipelvis had a well-developed mons pubis, clitoris, etc. There were palpable pubic bones of both hemipelvises. The baby had a right cornea opacity, which you're going to see. He had right ectopic kidney as well, which was located in the right iliac fossa. There was a urinary bladder and a uterus, which were centralized. Now, the child was subjected to a number of investigations to help identify associated anomalies and plan the way forward. So if you look at the slide on your right-hand side, this shows the X-ray, whole body X-ray that was taken before the surgery. And you could see well-formed femora. You can count 4 femora with traradial cartilage well-formed for each of them. Now, if you look at the perineum, you could see the vagina opening with fecal swelling. So this baby was passing feces through the vagina. So there was a rectovaginal fistula. There was imperforate anus, no inner orifice. And the one you see most posterior was the myelomeningocele. So whole body CT scan was done to look for other anomalies. We did MRI of the spine. We did echocardiography to rule out congenital heart disease. They all proved to be normal. So the baby was prepared for surgical reconstruction. The goal of the surgery was to disarticulate the two medial lower limbs that appeared to have low power and appeared less developed as opposed to the lateralmost limbs. Now, I must mention that because of the imperforate anus, the baby had earlier undergone a transverse colostomy. As you can see, the opening, just to divert the feces as the reconstruction procedures took place. So what surgery did we do? What we did was that we disarticulated the two most medial hips, and then brought the two hemipelvises together and held them with earthborne sutures, and then reconstructed the soft tissue. So this was the ventral appearance of the baby in the immediate post-operative period. On your right-hand side is the dorsal appearance after excising the supernumerary limbs and reconstructing the soft tissue. The limbs were sent for histopathology to see if anything interesting could come out. And the report was that there was abundant fatty tissue. Nothing else was seen. So on your screen now was the gross appearance of the histopathology specimen. Histopathology also reported the histology. There was nothing interesting. They reported that there was maturation of cartilaginous growth plate that was consistent with the age of the child. The pathologist also reported endochondral ossification. So we repeated the X-ray post-operatively, and this was the child 10 days after surgery. The child looked well. And on your right-hand side, you could see that the accessory femora were now not showing. The triradial cartilages that were redundant were successfully removed. On day 12 after surgery, the child looked well. We had a breakdown of about 4 cm or portion of the incision over the right ischium. Otherwise, the child was hale and healthy. At 8 months, the child is sitting, as you can see. Now, we saw the child yesterday, just before this presentation, to assess the most current state. And we saw that the child was doing well. She turned 2 years last week. And now the incision sites are now uneventful. All the wounds are healed. Power in both lower limbs, 5/5. And the pediatricians, the pediatric surgeons have reconstructed the inner opening, and they are waiting to return the transverse colostomy very soon. So we repeated the X-ray of the pelvis at 2 years to see whether our femoral epiphyses were well located. And if you look at the AP plain X-ray of the pelvis, you can see that the proximal femora and the epiphyses are satisfactorily located in the triradial cartilage. Now, at this age, the child is able to mention the names of her siblings. He says, Mama. Is able to read the alphabet from 1 to 5. He's able to hold to stand. So this baby is going to be followed. There has been some form of developmental delay because at 2 years supposed to be walking, but it's now holding to stand. So you follow up to see how she does in terms of achieving developmental milestones. How does this fit into contemporary literature? We've done extensive literature search, and we yet to see a similar case of ours reported in the literature. There was a case that was reported in Niger of a similar patient with polymelia, but that baby had only 1 accessory limb instead of 2 that we had in our case. And the baby reported in Niger had no sensory or motor function in the lower limbs. And that case also the mother underwent prenatal ultrasonography at which the abnormality was detected. And therefore, the mother was not allowed to go into labor. She was delivered by elective cesarean section. What is interesting about our case is that this child had power in all the 6 limbs. She has motor function, sensory function in all the limbs. And this diagnosis was made at birth. It was made at birth. So the risk was that if the mother had gone into labor, probably it would have been a disaster. Now, upon all the investigations, we've not been able to identify the predisposition in this particular case. And what I see explains the favorable findings is the thorough radiological evaluation that preceded the procedure, just to rule out all associated anomalies before undergoing surgery. Now, to conclude, when you have a malformation such as this one, and it is able to, and the child is able to undergo thorough investigation, our lesson from our case is that it maximizes your chance of undergoing a successful or undertaking a successful surgical procedure. Surgical intervention has been proved in our case to be safe in children with these rare severe malformations, and the intervention may optimize their survival. And again, the cause of the malformation is usually not evident at the time of the diagnosis. At the same time, if the child is well prepared, surgery can be safe and the outcome may be favorable. So our recommendation upon management of this case is that polymelia is a rare case and is rarely reported in the literature. And we recommend that we need to investigate this malformation to deepen our understanding of the etiologenesis and its long-term outcomes following successful surgery like we have done. Thank you for your kind attention.
Superb presentation, Dominic, as usual, and fantastic management of this extremely rare and challenging case. I think one very important point that I take away from this is the need for multidisciplinary approach to these complex cases, planning, which obviously you've done in an exemplary fashion here. One question from the audience is, how did you assess the muscle power and what was done for the myelomeningocele? Did you have neurosurgeons involved with this? Obviously, you mentioned the pediatric general surgery team that reconstructed the bowel. Can you speak a little bit about that?
Yes, the muscle power was assessed when the child was stimulated. So if you tap the feet, the child will cry and then throw all the limbs into the air. So we could tell the extent to which the upper limbs were moving, the lateralmost lower limbs were moving, and the 2 innermost lower limbs had flicker of movement, even if you stimulated with a strap of the finger. Then, as I mentioned, it was a multidisciplinary management. We had the pediatric surgeon, the neurosurgeon attend to their respective areas, but the orthopedic surgeons addressed mainly the lower limb malformation, doing the disarticulation, removing the ossific nuclei. All was done under fluoroscopy just to be sure that we did not leave any accessory bone behind.
Thanks, Dominic. And just looking at the hip, and granted, I'm not a pediatric surgeon, so please forgive my ignorance. Is this going to require varus-producing osteotomy and potentially like a PAO or something for the hip? I mean, it does look like there's still some residual deformity there. Nothing to address immediately, perhaps, but something that you're thinking about for the future?
Absolutely. So nothing to address immediately. This child is doing well, holding to stand. So I think that we're going to follow her up. If there is need, if the need arises, to do an intertrochanteric osteotomy to have a concentrically located femoral head later in future. We're going to do that. But for now, I think that whatever there is, we can get well containment of the head. The mother carries her at the back most of the time, so that with the hips abducted at the back of the mother, we can ensure well-developed acetabulum as the child grows.
Great. Since we're running low on time, a few comments from the faculty. Anybody want to make some comments on this case before we wrap up? Amanda, please.
This case is amazing. Excellent job. She looks very well. I guess my concern as from an orthopedic standpoint is how did you go about evaluating the blood supply to the supernumerary limbs? I would expect there might be some collateral circulation that if you weren't prepared for, it might be difficult to manage intraoperatively.
Yeah, Amanda, I could barely hear your question. Could you come up?
Yeah, let me repeat myself. This is a fantastic job. My question is, how did you preoperatively evaluate the circulation to the supernumerary limbs? My concern as a surgeon would be that there might be some collateral circulation to the residual, to the limbs that you're going to keep that might be hard to manage intraoperatively.
Well, preoperatively, we wanted to do CT angiography, particularly to assess the limbs that we are going to excise. But that could not be done for technical and cost reasons. So, well, that limited that investigation. But we saw that the limbs that were going to be salvaged or preserved appeared well, appear pink and appear well vascularized clinically.
Thanks, Dominic. Any other comments? Yes, Mihir, go ahead, please.
I think this looks amazing. Just wondering how, you see the bone below that right hip that is now articulating with the remainder of the pelvis on the left side. Is that something that over time you've seen change with? Is it something that is going to grow? And is that something that affects your bladder bowel function?
Yeah, thank you for your question. So this is actually the first postoperative pelvic X-ray that we've done 2 years down the line. This was done yesterday. So what you see, as I mentioned earlier, we will follow up and see how these bones get together as the child grows. So for now, I think that if you look at the right side, okay, this is the acetabulum, and then the earlier part and the triradial cartilage, the relationship does not appear significantly distorted for one to be worried. So I think the anatomy as we see on the X-ray are satisfactory for now. And as we follow up the child, you will decide if the need arises for any bony anatomy to be corrected.
Yeah, amazing. Yeah, we've never obviously dealt with any of this, so it's just wonderful to see how you manage this and how good she looks. So congratulations.
Thank you, sir.
Truly exceptional case, and what a note to end on. So thank you very much, Dominic, for this fantastic presentation. I think some excellent points made by the faculty. I would, of course, in a case like this, highlight the fact that you extensively preoperatively planned it. You just made the point in relation to Dr. McCoy's comment about the blood supply, worrying about the amount of bleeding you could get into when removing these limbs, worrying about compromising the blood flow to the remaining limbs, the nerves, this is so complicated. So I think for all the junior folks on the call, I think that this is something really aspirational. So thank you for presenting this, Dominic. Emily, do you mind pulling up the final slides? We'll wrap up now and say thank you to everybody. We've just posted the survey for this this session in the chat. So please, those of you who have attended, please do give us some comments, help us make this better. Emily, take us away.
Yeah, well, thank you everyone for coming, and thank you for all the incredible presentations we saw today, and for all of the faculty input. I think the discussion we had today was really great. So thank you everyone for being so engaged. Just some final things, like Kieran said, we have the post-conference survey here, so you can scan the QR code or go to the link in the chat. If you complete all of the pre and post course surveys for all 3 sessions, you'll receive a certificate of completion at the end of the conference. So look out for that. And then if you're interested in getting more involved with the Harvard Global Orthopedics community, we have lots of different WhatsApp chats for people to join. So feel free to scan any of these QR codes that seem most interesting to you. And then on the horizon, we have our complex upper extremity conference, which will be launched in November and hopefully have sessions in December. So if you have any interest, please keep this on your calendar, and we'll be sending out requests on what types of topics people want covered in cases and such stuff like that. And that pretty much wraps it up. So thank you so much for joining today. And if you have any questions or comments, feel free to send us an email here. We have our pre-conference survey on the left here and post-conference survey on the right. Just a reminder to fill these out to get your certificate of completion. Thank you.
Thanks, Emily. We can leave this last slide up just for folks as we end the meeting. Thank you so much to all the faculty, to all the case presenters. These meetings are always so inspiring for me. I, as a non-pediatric orthopedic surgeon, but someone who does have to manage upper limb pediatric cases occasionally in limited resource settings, this has been very eye-opening, and I learned a lot. And I really thank you all. Thank you very, very much. Take care, everybody. We'll leave this slide up and just allow people to take a moment to fill out the surveys. Thanks a lot. Bye. See you next week for chronic osteomyelitis.